Hello class, this is Mrs. Correa. Welcome to week 4 lecture, Nursing Care of Women with High Risk Pregnancy. Topics included are placenta previa, abruptio placenta or placental abruption, premature rupture of membrane, preeclampsia and eclampsia, multiple gestation, GBS infection and torch infections. Placenta previa. Some people call it as placenta previa also. Placenta previa is an implantation of placenta in the lower uterine segment near or over the internal cervical os. There are three types of placenta previa: complete placenta previa, partial placenta previa, and marginal placenta previa. Complete placenta previa, where the placenta covers the entire cervical os. In the partial placenta previa, the placenta that partially occludes the cervical os, so it is not completely covering. In the marginal placenta previa, encroachment of the placenta to the margin of the cervical os. Signs and symptoms of placenta previa are painless vaginal bleeding. Please remember this. In placenta previa, most of the time, vaginal bleeding is painless, and in abruptio placenta or placental abruption, the vaginal bleeding is painful. This is how you differentiate placenta previa and abruptio placenta clinically, and I have discussed that in the previous lecture also. Bleeding may occur recurrent, and bleeding may be bright red in color. Some of the fetal risks are premature birth, IUGR, malpresentation, congenital anomalies, and vasa previa. What is vasa previa? It is the umbilical cord is implanted into the membrane rather than placenta. That is called vasa previa. Maternal risks are uterine rupture, potential for emergency hysterectomy, postpartum hemorrhage, shock, and death. The management focuses on stabilization and fetal monitoring. Remember this: no vaginal exam to be performed on these patients, and I want you to find the answer for that. And in case of active bleeding, provide bed rest. If time permits, administer betamethasone, so that the fetal lung can be matured. Let us discuss about nursing management. We need to recognize manifestations of maternal stress associated with diagnosis, such as anxiety, feeling of helplessness, fear of pregnancy loss, fear of self, confusion, panic, difficulty in decision making. And we need to help in reducing anxiety by carefully explaining and provide educational materials. What is abruptio placenta or placental abruption? It is the premature separation of a normally implanted placenta from the decidual lining of the uterus after 20 weeks of gestation. The etiology and risk factors and classifications are going to be discussed now. At the initial point of placental separation, non-clotted blood courses from the site of injury. Then the enlarging collection of blood may further cause separation. And this bleeding can be either concealed or internal bleeding, or revealed or apparent bleeding. And I want you to refer from your book for the classification of abruptio placenta and the management of abruptio placenta. The risk factors of abruptio placenta are maternal hypertension, cigarette smoking, multiparity, abortions, illicit drug use such as cocaine, methamphetamine, short fetal umbilical cord, maternal abdominal trauma, rupture of membranes, uterine leiomyoma, that is fibroids located behind the placenta. Signs and symptoms. Third trimester bleeding associated with severe abdominal pain is a classic sign, or it is called the hallmark sign of abruptio placenta. Uterine tenderness can happen, abdominal pain or back pain, board-like abdomen and no vaginal bleeding. This can occur in concealed hemorrhage, abnormal contractions and increased uterine tone, Late decelerations, this can occur due to fetal compromise. Bradycardia and lack of variability. You want to see some variability when you do fetal monitoring. So when there is lack of variability, you should suspect abruptio placenta also. And fetal demise also can happen. Diagnosis is done by clinical findings and ultrasound examination. Management is monitoring and necessitates delivery in some cases, cases such as when there is severe bleeding, then we should be delivering the baby as soon as possible. And nursing management focuses on continuous maternal fetal assessment, ongoing information, and emotional support for the patient and her family. Premature rupture of membrane. It is rupture of membranes before the onset of labor at any gestational age. Etiology of premature rupture of membrane are choriodecidual infection, decreased amount of amniotic membrane collagen, cigarette smoking, STIs, preterm delivery if there is any prior history of, and uterine distension like in multiple gestation and in polyhydramnios. Signs and symptoms of PROM. The women may feel a gush of fluid from the vagina or trickle of fluid from the vagina. And diagnosis is based on history and physical examination. And also when you do the speculum examination, you may see a gush of fluid or trickle of fluid coming out from the vagina too. And the vaginal fluid can be examined for the presence of amniotic fluid by doing nitrazine test, Anissure or Fern test. So this is to confirm the presence of amniotic fluid from vaginal discharge. And it can also be diagnosed by using ultrasound. Management of premature rupture of membrane includes established gestational age, ultrasound to assess fetus, assess for advanced labor and infection, and if advanced labor or infection occurs, we need to deliver fetus as soon as possible. Tocolytic therapy for 48 hours. In many hospitals, they institute this, although there is a controversy. This is especially done if gestational age is less than 34 weeks, and this will allow us to give time to administer corticosteroids to enhance fetal lung maturity. But what is the controversy? When you give tocolytic therapy, you are delaying labor and you are delaying the contractions. So when you delay this, if there is some infection already existing, that can advance and more complications can occur. The risks of maintaining pregnancy for fetal maturity are chorioamnionitis, placental abruption, and cord prolapse. The nursing management include education on need for bed rest. We need to do vital signs every 4 hours to check any signs of infections. Intermittent fetal monitoring is required, and we need to provide emotional support. Little bit about classification of hypertensive disorders are chronic hypertension, preeclampsia and eclampsia, preeclampsia superimposed on chronic hypertension, gestational hypertension, and transient hypertension. What is chronic hypertension? You probably want to know that. Hypertension that is present and observable before pregnancy, or hypertension that is diagnosed before 20th week of pregnancy is called chronic hypertension. Preeclampsia and eclampsia. Preeclampsia is an increase in BP, that is the systolic blood pressure greater than or equal to 140 mmHg, and diastolic greater than or equal to 90 mmHg, occurring twice 4 hours apart after 20 weeks of gestation, accompanied by proteinuria, that is excretion of greater than or equal to 300 milligram protein in 24 hours. So that is preeclampsia. And what is eclampsia? Eclampsia is the presence of new onset grand mal seizures and or unexplained coma in a woman with preeclampsia who has no other cause for seizure. So these women, they have no history of seizures or epilepsy, but along with preeclampsia, they get grand mal seizures and or unexplained coma. So that is eclampsia. So preeclampsia is a multi-system disorder. It is a vasopressive disease, and it is also a disease of the placenta too. And I want you to read the spasms mnemonic from your textbook. And there is always morbidity and mortality associated with preeclampsia. And I want you to read the preeclampsia risk factors from your textbook too. How to manage preeclampsia? The ACOG recommends preeclampsia without severe features can be managed at home after careful evaluation. And delivery of fetus is the only cure. You may use antihypertensive medications, but that can only control preeclampsia, but it cannot cure. So delivery of the baby is the only cure for preeclampsia. And the management of severe preeclampsia is seizure prophylaxis with magnesium sulfate. Although magnesium sulfate is considered as a pregnancy classification D, it is widely used in treatment of preeclampsia. And antihypertensive medications are used. Invasive hemodynamic monitoring is done. And also I would like you to read antihypertensive medications used in pregnancy from your textbook. Nursing assessment includes identification of hypertension, proteinuria, edema, CNS alterations such as seizures in case of eclampsia. Multiple gestation. Monozygotic or identical twins. In this case, fertilized single ovum or zygote splits early in pregnancy and develops into two fetuses. So that is called monozygotic or identical twins. Then dizygotic or fraternal twins, the ovulation produces two separate ova and each one of them is fertilized. Dichorionic and diamniotic, they have two chorions and two amnions. 25 to 30% of monozygotic twins will have dichorionic and diamniotic sacs. And monochronic diamniotic, it is presence of one chorion and two amnions. That occurs in 70 to 75% of monozygotic twins. And monochorionic, monoamniotic, that has only one chorion and one amnion. Multiple gestation is considered as high-risk pregnancy. Morbidity and mortality is high, and monochronicity, growth restriction, and prematurity pose main risk. What is monochronicity? It is presence of one chorion. And twin-to-twin transfusion syndrome is a main complication of monochorionic twins, and which results from vascular connections or anastomosis within the single monochorionic placenta. So this is a main risk, and that can lead to intrauterine growth restrictions, and sometimes either one of the fetus or both fetus may die. And management of multiple gestation is done. The delivery is preferably done in a level 3 facility, but I have seen twin gestation births happens at a level 2 facilities all the time, but we prefer to be done in a level 3 facility. The nursing implications are emotional support and encourage to voice their concerns, care of women and individual fetus. So remember, there are two fetus, so the care should be given to both fetus, and careful approach in fetal monitoring to identify fetal heart rate of each twin should be done. There are many infections can happen and dangerous to the mother and the baby, but I'm going to focus on group B streptococcal infection and TORCH for the purpose of this class. The group B streptococcal infection, it is a frequent cause of UTIs and chorioamnionitis and endometritis after pregnancy has ended. It is a major pathogen in neonatal sepsis that can result in significant neonatal mortality and morbidity. And women harbor GBS as part of normal fecal and vaginal flora. The neonatal infection that is more dangerous. The neonatal infection or neonatal sepsis with GBS is divided into two categories. One is early onset GBS and the second one is late onset GBS. The first one, early onset GBS, it is generally develops signs of respiratory distress, fever, septic shock in the first 12 hours of life. And in the late onset GBS, it is community acquired and can be nosocomial, environmental or maternal and presents more than a week after birth. Both are high risk. Early onset can be dangerous to the baby if it is not detected and not treated on time. Most of the time, if the baby has a fever after the baby is born, the neonatologist will order a septic workup, and depending upon the septic workup, that is CBC and the band counts, WBC counts, then depending upon that, we treat the neonate with antibiotics. We do not wait for a culture result to come back. We start antibiotics immediately if there are signs of infections in the CBC. But in the late onset GBS, this is very scary too, and we may not detect this late onset GBS early. So it could be a very slow process, and it could be dangerous to the patient, and the baby should be monitored for any signs of infection in the early lives or in the immediate coming weeks after the baby's birth also. To protect infants from GBS infections, CDC recommends obtain vaginal and rectal swabs from all pregnant women between 35 to 37 weeks of pregnancy. And positive cultures or unknown GBS status at the onset of labor, we need to treat the mothers with antibiotics. So you will see when you go to the clinical that GBS status is most of the time you will see negative or positive and treated times this many times of antibiotics is given, or GBS status is unknown. So when you go to the clinical, I would like you to see the patient's chart and try to find the GBS status of the mother. Torch infections. T for toxoplasmosis, R for rubella, C for cytomegalovirus, H for herpes simplex virus type 2 or HSV2, O for other type of infections such as hepatitis B, syphilis and HIV. And maternal exposure to torch infections during first 12 weeks of gestation is associated with fetal developmental abnormalities. These are very important. I want you to read from your textbook. Please remember to read this. And thank you for listening.